again, everybody. So in the second paper, I will talk about the relationship between electronic health records and Medicare reimbursements and how the recovery audit program that specifically started by CMS moderates this relationship. So fast rising healthcare costs have been an important public policy problem in the US over several years. And if the current trend continues, healthcare costs is expected to go as high as 40% of the GDP by 2050. So policymakers have been trying to find potential solutions to this problem. And HITECH Act is one example of that. So this policy devotes around $38 billion for digitization of health records, which led to a significant uptake of electronic health record adoption within the last decade. And the underlying belief behind these public subsidies is that electronic health records, EHRs, are going to improve the care quality and they're going to lower the healthcare costs. And when we look at the literature, we actually see quite a bit of evidence indicating that electronic health records improve the care quality, they reduce the medical errors, they improve diagnosis, so on and so forth. But there is some mixed evidence on whether they actually reduce the healthcare cost. And one potential explanation why they might increase overall healthcare costs is that electronic health record systems can increase reimbursement requests made by the hospitals. So the reason EHRs play a role in here is that information in the patient chart is essential in the coding and reimbursement process. So the information in the medical records is used to assign each patient to a diagnosis-related group, DRG. So this is for inpatients. And this process of assigning a patient to DRG is called coding. And the DRG classification basically groups similar patients together, and then hospitals get reimbursed in the inpatient setting at a fixed rate for each DRG, regardless of the services provided. So this is different context than the outpatient context where reimbursements are done based on the services provided. In the inpatient context, the reimbursements are provided on the diagnosis-related group that the patient is placed in. So insurers reimburse more severe and complex DRGs at a higher rate, and some small changes in this coding process can actually lead to big differences in the reimbursement rates. So hospitals have clear financial incentives to increase their coding as much as they can. And this issue is known as upcoding, when healthcare providers are reporting more serious and more expensive diagnoses and patients than the actual reality. And electronic health record systems plays a role in this coding process because they significantly change the way medical data is captured and recorded. And in this paper, we will be focusing on the computerized physician order entry system, CPOE system. So this is the main interface where physicians enter data into their visits. So if you take a look at an example of a CPOE interface, it could look something like that, right? So this is where the physicians typing constantly, right, during the visits. So it has some dashboard on treatments, medications, radiology, right, images, lab tests, so on and so forth. It has multiple pages. So all the relevant information about the patient's visit, right, the types of treatments, and I think in a further page, all the co-conditions and comorbidities that actually affects DRGs to a large extent will be recorded in the CPOE system. So one reason why CPOE system can play a big role in coding process is these systems come with default sets and automated data. So that means when a patient comes in, right, with a certain condition, the system can automatically insert the common treatments, common medications, common tests, and common comorbidities that is associated with that condition. And the main goal of having these default templates and auto-populated information is to help physicians with data entry, because now physicians bear a big burden of data entry using electronic health records. And whenever we talk to physicians about this, they don't like it, right? Because it takes a lot of time to enter the data and they have to interact with the patient at the same time. So it is challenging for them. So one benefit of having these default templates is save physicians time for data entry. But on the other hand, now physicians are expected for each case evaluate and say, okay, this default information does not apply to this specific patient, and take it out, right? And we know that physicians also are very busy. They don't have that much time for each visit, so they have limited time and information processing capability. So some of this information that is added as a default, and if the default information is biased in a certain way to report more complex patients, some of it will eventually remain in the system. So the first main mechanism that CPOE systems can change coding is this automated data entry with default templates and order sets, and some of them will eventually remain make its way into the medical records. Another functionality of these systems is cloning data and copying, pasting previous records. So when the patient comes in, if you have a previous record of the patient, we can just copy and paste from the previous record. And if we had some extraneous information in the previous record of the patient, so this will keep remaining into the further records. So this additional information that can be easily added into the medical records can be used to report sicker patients and to justify more intensive care than actually took place, to be able to increase the reimbursements from Medicare and other insurers. And of course, such inflation in coding of patients' diagnoses would increase the overall healthcare spending. So there has been several concerns for upcoding, and there are many anecdotal evidences. For example, some hospitals are found to increase their Medicare reimbursements almost by 80% after they adopted electronic health record systems. So of course, these took a lot of attention from the government and from the Medicare, and there were some warnings sent to all hospital associations and hospitals directly as well. So this is a letter sent by the US Department of Health and Human Services and US Department of Justice to several associations. Of course, you cannot read this, but I will just highlight this part. That they acknowledge electronic health records have the potential to save money and save lives, but they have some indications that these technologies are used to game the system perhaps, or using the electronic health records to facilitate upcoding of intensity of care and severity of patients is a way to increase profits for hospitals. And this letter warns that this is not acceptable, and they will face certain penalties and legal action. And these consorts for upcoding created a whole audit program by Centers for Medicare and Medicaid Services Recovery Audit Program. And this audit program had a staggered implementation. So the first wave was in 2005 in Florida, New York, and California. And these are the states that have the largest share of Medicare reimbursements. And the second wave went into Arizona, Massachusetts, and South Carolina. And in 2010, all 50 states have this recovery audit program under implementation until this day. And there are 4 companies, and each state is assigned to a company for the audit. So we cannot observe the exact time of auditing for hospitals, but we know that once the audit program is implemented in a state, all hospitals get audited on a rolling basis. And some of the audit contractors have specific capabilities of identifying cloned information and over documentation that are more directly related to digital records. So this program has consequences for hospitals because they can face denial of reimbursement, financial penalties, and in more severe cases, they can face legal action and prosecutions. So just a couple of examples of healthcare organizations paid significant amount of money to settle the allegations for upcoding. So this program has important consequences financially and legally for hospitals. So if you look at the audit literature, we know that audit and oversight has several positive effects. It increases data quality, reduces financial statement fraud, reduces earnings mismanagement, material misstatements. So we know that data verified by auditors are more accurate, informative, and useful. So overall, we can expect this oversight to improve data quality and accuracy in this healthcare context as well. So our research questions will be whether the CPOE adoption increased reported patient complexity in hospitals? And if so, whether a recovery audit program has a role in changing this relationship. So overall, we find that there is indeed a positive relationship between CPOE adoption and reported patient complexity, and the audit program completely diminishes this relationship and has been effective in attenuating upcoding or coding inflation. So to test these research questions, we gather data from different sources. We use patient-level data, again, from HCUP between 2004 and 2014. So in this case, we selected 4 states, Florida as an example of a state that was in the first wave of recovery audit implementation. Arizona was in the second state, and Maryland and Kentucky in the last wave. So we pick states based on the audit implementation rollout. And we observe the universe of all inpatients and all their visits. We know the patients in which diagnosis-related groups they are placed in, the disease category they are in. So we can calculate a measure of patient complexity for the hospital, or in this case, we do it by disease category. And we again use HIMSS data to gather CPOE and other electronic health record adoption at the hospital level. We filed a Freedom of Information Act request to figure out which auditors have capabilities to detect copied and over-documented information that is more applicable to digital records. And we gather controls from Medicare cost reports and regional controls from the US Census database. So in terms of measuring patient complexity, so we have information on patient coding for each patient visit. And in general, there is an overall disease category that patients are placed in. So the disease category could be something like knee procedure. And each disease category has 3 levels of complexity. The baseline is knee surgery or knee procedure with no complications or comorbidities. The second one is knee procedure with complications and comorbidities. And the third one is with major complications and comorbidities. And as the severity level increases, the reimbursement rate goes up accordingly. And following the prior literature on this, we are calculating proportion of patients with major complications and comorbidities within each disease category as a measure of reported patient complexity. So our each unit of observation is a disease category hospital combination, and we track those disease category hospital combinations over the years to see if CPOE adoption had an impact. So our audit variable is a simple binary variable because we are not able to observe the exact timing when the hospitals are audited, but we know that they're being audited, so we interpret it as more like oversight and presence of auditing. So this variable is equal to 1 for Florida, is starting from 2005. Florida is in the first wave. In Arizona, starting from 2007, and all the other states get 2010 and after for auditing. And we also have a binary variable for each state years that have the auditors that have specific capabilities for identifying copied and over-documented information that relates to more digital records. So we also have a binary indicator for this different type of audit. We can differentiate between the 2 types. So in our main empirical specification, our dependent variable is proportion of patients coded with major complications within a disease category in hospital I within a year, in a given year. We look at the CPOE adoption of the hospital. And again, we want to, our main coefficient of interest here is the interaction between CPOE and audit. And we also control for some hospital level metrics, county level factors that can affect the complexity of patients in the area. In this case, since our each observation is a disease category hospital combination, we do a disease category times hospital fixed effects. And then we do also include year fixed effects. So again, before going into the main results, I will talk about the endogeneity challenges and what do we do about them, because I won't present those results, but again, we can go into it if there is a question about them. So the main, I think, endogeneity challenge in this relationship is the positive relationship between CPOE adoption and patient complexity can be due to real changes, right? What if these systems make the interactions between physicians and patients richer and enable them to capture information that they could not capture in the paper-based records, but this is a real change, right? Real increase in patient complexity. And also another alternative explanation here could be that these systems are perhaps attracting more complex patients. So especially in the early years, maybe hospitals that have CPOE systems are more advanced hospitals that are attracting sicker patients. So they see an increase in their patient complexity, but again, it can be due to a real change, right, in their patient composition. So to address these alternative explanations, we first look at the impact of the recovery audit program, because we expect if the positive relationship between CPOE and patient complexity is real, it should persist when hospitals are being audited too, because all these changes should be justifiable. And second, we look at changes in the patient profile of the surrounding neighboring hospitals of the focal hospital, because if the focal hospital is attracting more complex patients, then the surrounding hospitals should get the less complex patients, because in a given year, overall patient pool doesn't change in a healthcare market, but we do not find any evidence of such patient complexity changes for the focal hospital, or attracting more for the focal hospital and having spillovers onto the other ones. And also we do not find evidence that, right, this positive relationship persists under the auditing program. We also use some instrumental variables to address unobserved confounding factors. So in this case, we use two IVs. So one of them is, again, peer hospitals, neighboring hospitals, CPOE adoption, because in the literature, there is evidence showing that the regional competition and the peers hospitals IT adoption decisions affect the area and the other hospitals in the area. We also look at the number of their non-clinical IT systems, because some hospitals might be more tech savvy and have all these health IT systems, but non-clinical IT systems, right, will be correlated with their clinical CPOE adoption, but it should not be, it cannot affect directly the coding practices. So we use that as another instrumental variable, and we find the results are robust. So here also we use a relative time model, because it's important to understand the pre-treatment effects. We do not find any significant pre-treatment effects leading up to the adoption. And also we address whether there are systematic differences across these regions. Even though we control for several regional factors, there might be still some information remaining there. So we try a matching across the states to show that results are robust. Okay, so if we look at the main results here, so looking at columns 1 and 2, we do not find for the entire panel any significant relationship between CPOE adoption and reported patient complexity of hospitals. So this is for the entire panel, including hospitals that faced audit at different stages. And in column 3, once we decompose the hospitals that faced the audit here, the second coefficient, versus the ones that were not audited, now we start seeing differences. So the hospital years, in this case, that are not being audited has a positive relationship between the CPOE system and the reported patient complexity within each DRG, each disease category. And then once the hospitals are audited, this relationship diminishes, and actually when we add up the coefficients, they become statistically insignificant. So then we look at the early audit period, the pilot period before 2010, because one criticism here can be maybe something else happened in 2010, right, that coincided with the nationwide rollout of the recovery audit program. So why don't we look at the years before 2010 and see if the early audit program gives us similar results. So in this case, we find the coefficients to be similar even before 2010, before the nationwide rollout of the audit program. We see that hospitals who are not audited are increasing their patient complexity via CPOE adoption, And when the hospitals are audited, this relationship goes away. And lastly, we look into the auditor capabilities as one of our part of our main results. So the auditors with copy identification are the auditors that have capabilities to identify cloned and over-documented information that relates to more digital records than paper-based records. And these are the hospital years are audited by different types of hospitals that are not reported that they have this capability. And again, the baseline is no audit. So these are hospital years that are not being audited at all. Again, we see that the CPOE has a positive effect on reported patient complexity. And we find that both types of auditors are effective, but auditors with the copy identification capabilities are statistically significantly more effective in reducing increased patient reporting via CPOEs compared to the other types of auditors. Okay, so I think these are all my main results. So overall, we find that CPOE adoption increases reported patient complexity in hospitals, and once hospitals are audited, this relationship goes away. And if we take these estimates and do a back of the envelope calculation, it indicates that without an audit, CPOE adoption increases Medicare expenditures about $1 billion a year. So this indicates that, right, these systems have several benefits, but they can also have some unintended consequences. And so here, policymakers can strengthen the audit programs and auditor capabilities to fight with this digital over-documentation, to fight with this increase or inflated codes. And also, but that doesn't mean, right, the auditors are also, the recovery audit program is also funded by the public money. So it doesn't come for free. It's great that it's effective in reducing upcoding, but we still have to pay for the auditing program. So perhaps different types of auditing methods, continuous auditing, can make the recovery audit program more efficient and effective and save some of the costs on that. Okay, I think that's all I have for this presentation. Thank you very much.